Welcome to this lecture on PET-CT infection and inflammation imaging. The objectives for this presentation are to understand the methodology of PET-CT inflammation and infection imaging, list the indications and contraindications for PET-CT inflammation and infection imaging, explain the patient prep, describe the imaging protocol, analyze images, and then recognize normal and abnormal distribution on FDG inflammation and infection images. So the methodology for infection imaging with FDG. FDG is a glucose analog that accumulates in cells via glucose transporters. Cells that are included in inflammation and infection processes have an overexpression of glucose transporters. The overexpression of GLUT1 subtype in the stimulated macrophages, neutrophils, and lymphocytes. The activated inflammatory cells accumulate FDG with high concentration depending upon the degree of stimulation that is a function of inflammatory activity at the respective site. Inflammation and infection cells will accumulate more glucose due to the overexpression of GLUT1, resulting in increased uptake in areas of inflammation and infection. The clinical indications for infection and inflammation imaging with FDG are listed below. This is not an all-encompassing list, but these are the most common indications. Sarcoidosis could be systemic or cardiac. Tuberculosis, osteomyelitis, and spine or peripheral. Fever of unknown origin, recurrent sepsis, neutropenic fever. Metastatic infection and high-risk patients with bacteremia, vasculitis, evaluation of infected liver and kidney cyst and polycystic disease, orthopedic and internal device infections such as pacemakers, joint replacements, or indwelling catheters, and AIDS-associated opportunistic infections. Contraindications of FDG imaging include pregnancy or breastfeeding and any recent interfering nuclear medicine exam. These are relative contraindications. The risks and benefits need outweighed with the patient and the doctor to determine what is the best course of action. Recent interfering nuclear medicine studies would be anything that is a PET radionuclide, especially anything that is fluorine F18 based. Lack of proper patient preparation, and then a blood glucose level greater than 150 to 200 milligrams per deciliter. That is based on the department protocol. Some of them may err on the side of caution and have a lower limit of 150, while others may have 200 or set their own limit. The patient preparation is to avoid strenuous exercise for 24 hours prior to the injection. We want to minimize any of the uptake that's in the muscle or the brown adipose tissue. Nothing to eat or drink for 4 hours prior to the test except for water. Patients should be well hydrated and they should take their medications as usual except for steroids. For diabetic patients, they do have additional patient preparation. Diabetic patients should take their medications early in the morning, for example, before 7 a.m. And then the scan or the patient should be scheduled for later in the morning or early afternoon. The last thing that was on there that I kind of skipped over was the uptake period, which is 16 to 90 minutes, but we're going to talk about that in a second. Patients should be consulted if they're diabetic to determine what their baseline blood sugars are and the extent or management of diabetes. Ask direct questions. Do you regularly perform fasting blood glucose levels? If so, what's your normal levels? Do you have a journal that you do? And then, are there periods of high or low glucose? If they are insulin dependent type 1, you want to schedule them as early as possible in the morning. That will cause less disruption to their normal blood sugar levels and medication schedules. Non-insulin dependent type 2 diabetics may have a light breakfast and schedule them in the afternoon because they just need to be NPO for 4 hours. Have the patient bring all their medications with them though, especially if they have medications for diabetes, because we are giving them something that's a sugar analog that can disrupt their blood glucose levels. Review patient history very carefully and record any metabolic conditions or hormonal abnormalities that the patient knows about. Always watch the patient for hypo or hyperglycemia, and know your policies in your department for managing low and high glucose levels. Typically, if the patient is a little bit low blood sugar, it's still okay to give the FDG because you're giving them sugar. Theoretically, you're helping them. But if their blood sugar is too high or unstable to start, then it may be contraindicated. You may need to reschedule them. You always want to perform a fasting glucose before you inject them, and you may treat and repeat until the patient is within the desired range for injection. Like I said, though, if it's too high, a lot of protocols would just go ahead and cancel and reschedule the patient. Fasting glucose levels should be between 90 and 120. It's okay if it's a little low or a little high to still give the procedure, but you do need to document what their blood sugar was. Some facilities will inject with glucose levels as high as 200, but most have switched to using about 150 as the maximum. And patients with diabetes have inhomogeneous or inadequate tissue activity due to competition with non-radioactive glucose. When your blood glucose levels are really, really high, the cells in your body tend to be saturated with glucose, and they're not really taking up any more glucose, which is why it starts to build up in your blood and you get high glucose levels in your blood. So if we come along and inject more glucose into that, it's just going to raise their blood glucose levels, but it's not really going to concentrate in their cells because it's already saturated with non-radioactive glucose. So there's really no point in injecting them if their blood sugar is too high. It's going to raise their radiation exposure and raise their blood sugar to even more dangerous levels, but we're not going to get any of the benefits of imaging because it's not actually going to uptake into the cells. Some patients may require glucose or insulin depending on their glucose levels. Most protocols allow patients to continue normal snacking schedule after they're injected. So this is showing you the effects of glucose on FDG uptake. You will take typically an Accu-Chek or just a finger prick test of the glucose. Ideally, it should be less than 120 for injection. So image A is less than 110. B is 110 to 159. C shows you what it looks like with 160 to 179 as the blood glucose. And then D is showing you about 180 to 200 for the blood glucose. So you see the visual qualitative comparison demonstrates that FDG uptake in the brain was markedly reduced with higher blood glucose levels, whereas there's really no difference in the liver or the lungs. So if you look at A was the one with normal blood glucose, and then you see how it progressed down to D. And that's because the brain is already saturated with normal non-radioactive glucose, so it's not taking up that FDG. So in diabetic patients and patients that are prone to hypoglycemia, it is important to watch for that. Is there a time when blood sugar trends high or low? Something that you should ask the patient. For type 1 diabetics, early morning fasting and no insulin unless it's necessary. For type 2 diabetics, scan them in the late morning or early afternoon. Give them a light meal in the morning, oral medications, and then ask that they fast for at least 4 hours and watch for signs of hypoglycemia. Those signs are listed on the left side of the slide: shaking or trembling, faster heart rate, extreme hunger, sweating, confusion, difficulty concentrating, and dizziness. There are quite a few questions that you should ask patients when you're getting ready to scan them. If they have a history of diabetes, what their fasting glucose level is, that should be obtained before injection. Presence of fever, ask about a history of fever, how long it's lasted, how high it's been. Presence of known infections, inflammatory conditions, or immunosuppressive status. History of trauma, recent surgery, recent invasive procedures, presence or recent history of pain, history of cancer, chemotherapy, or radiation therapy, results of laboratory tests, including inflammatory markers, erythrocyte sedimentation rate, and C-reactive protein are good examples of laboratory tests that need to be recorded. And then results of any other imaging. This could be CT, MRI, perhaps they've had a tagged leukocyte scan with either TEC or indium. That would be something to add to the patient history and include those results as well. Just to review the radiopharmaceutical, it is F18 fluorodeoxyglucose. That is fluorine 18, which is cyclotron produced, decays by positron emission. Has 511 keV with a max energy of 635 keV. The physical half-life is 109 to 110 minutes. And then the radiopharmaceutical is fluorodeoxyglucose, also known as FDG. This is a glucose analog, concentrates in cells that rely on glucose for energy, and concentrates in cells whose pathophysiologic conditions demand more glucose. This is showing you the mechanism for FDG uptake within the cells. It goes by glucolysis, which is a hexokinase enzyme and adds a phosphate. This happens to both glucose and FDG. The second step is another enzyme that turns glucose into fructose. This does not happen with FDG, so the FDG becomes trapped within the cell. FDG will avidly accumulate in inflammation and infection for a couple different reasons, but mainly because these cells have overexpression of glucose, the GLUT1 transporter on the surface of the cell. The method of localization is a facilitated diffusion. It's passive movement across the cell membrane, but it is a selective process. So the kit contents for FDG, it is provided to use isotonic sterile, pyrogen-free, clear, colorless citrate buffered solution. It comes in 10 to 100 millicuries per milliliter. 4.5 milligrams of sodium chloride, 7.2 milligrams of citrate ions. The pH should be between 5 and 7.5, and then there are no preservatives. The dose for FDG will vary a little bit. Part of that is based on protocol, part of that is based on the scanner. But it's 5 to 10 millicuries metabolism or active transport for localization. It is considered facilitated diffusion. Part of it is passive, but it's a very selective process. And so you may see the dose range be anywhere from 5 to 20 millicuries for FDG. It is administered intravenously. Patients need to have fasted for 4 to 6 hours. They can still drink water, that's okay, but nothing else. And blood glucose levels not only need to fall between below 150 to 200, depending on what the facility protocol is, but the blood glucose level must also be stabilized. For the pediatric dose, this is calculated typically based on weight. There is a minimum dose of 0.7 millicuries, and the recommended calculation is 0.1 to 1.4 millicuries per kilogram. This is an overview of the basic procedure. First thing you'll do is identify the patient using two methods. Typically, you ask them their date of birth and their name, and you check their wristband. Verify that with the order. Have the patient change or remove metal. They don't necessarily need to change into a gown, but they do need to make sure that they remove all the metal, so that will attenuate, and it will also create an artifact on the CT portion. Record the patient's height and weight. That's used sometimes for SUV calculations. Obtain the patient history and reconcile all medications. Measure the patient's blood glucose. At this point, if the blood glucose is okay, then you're free to start the test. If it's high, you'll probably need to call the doctor. That's a little bit depending on department protocols. Sometimes they'll just cancel the patient, and then you can start the IV as long as it's okay to start. Inject 5 to 15 or 5 to 20 millicuries of FDG, whichever is prescribed by your department, and then flush that IV really well. Typically 20 cc's is good saline flush. Make sure that all of that FDG came out of that catheter and is not kind of hanging up in the catheter. And then there's always a question whether or not to discontinue the IV. It may be a good idea to leave it in case the patient has any issues before you get them on the camera. Otherwise, you may remove it. That depends a little bit on your department protocol. And give the patient a warm blanket. Make sure that that will reduce the amount of brown adipose tissue that accumulates, and have the patient rest for about 60 to 90 minutes while the FDG uptakes. Right before they go on the camera, have the patient void. We do want them to have an empty bladder. Position the patient supine on the camera. Depending on what you're scanning, they will either be arms up or arms down, but they will always be supine, pretty much always be supine. Make sure that you give them any breathing instructions. It is a good idea to let the patients know that they do not need to hold their breath, but they do need to hold still. Sometimes patients get confused with the PET-CT scanner versus a straight CT scanner, and sometimes they may think that they need to hold their breath the whole time. Select the appropriate patient and protocol on the scanner. The first set of images will be the CT scout images. That's where you'll set the scanning parameters moving forward. After that, you perform the CT portion that's later used for attenuation correction, and then the PET scan is acquired at about 2 to 3 minutes per bed position. These are the acquisition parameters. So the uptake time is about 60 to 90 minutes. Position the patient supine. If the suspected infection is in the chest or the body, you may be able to bring their arms up above their head and scan them from eyes to thighs. But if you have a fever of unknown origin or some other infection that may go to the whole body, then you're going to want to scan the whole body from vertex to the tip of the toes. In that case, you may want the arms down, especially if it's head and neck pathology or there's suspicion in the extremities. Acquisition mode may be 2D or 3D. That depends on the manufacturer's recommendations. Scan parameters could either be total body vertex to toes, or it could be skull base to mid thigh. For cardiac sarcoidosis, it is acceptable to just scan the heart in the field of view. Bed positions, it's 10 or more for the total body, and the skull base to the thigh is 5 to 8. Time per bed position, 2 to 4 minutes for body scans, and 10 minutes for limited field of view. Attenuation correction, CT is optimal and per the manufacturer's recommendations. CT is great, especially you're using attenuation correction and iterative reconstruction. CT provides a better quality image. This is, so there are some special considerations. First, patient being evaluated for pelvic infections, it may be beneficial to have a urinary catheter installed that will keep that bladder nice and clear from urine. All patients should void before imaging anyway to keep the bladder nice and clean, or nice and clear from counts. Auxiliary medications that may be used, beta blockers, lorazepam or diazepam, may be given to reduce the uptake of brown adipose tissue or skeleton muscle. So the preferred reconstruction is using CT. Iterative reconstruction method is preferred. You will create axial, coronal, and sagittal views, and then you will scale that, and it'll be displayed as the CT, the raw PET images, and then the fused PET images. The normal biodistribution includes glucose, the FDG being transported through cell membranes through the facilitated glucose transporter proteins. Then it's phosphorylated within the cell and is trapped within the dephosphorylated cells. And then at 45 minutes, the FDG accumulation plateaus in tumors. It's about the same for infection. At 2 hours, the highest activity levels are seen in the brain, heart, if not fasting, and urinary system. This is primarily excreted through the urine. Normal biodistribution will appear in the brain, liver, kidneys, bladder, salivary glands, thyroid, heart and vascular structures, spleen, esophageal ampulla, stomach, bowel and the colon, the endometrium during menses, bone marrow, muscles, and testicles. You'll also see the thymus in children. Because pretty much every cell in your body uses glucose, the normal biodistribution is varied. So this is another example of normal biodistribution. This is a coronal view at several different slices through the same patient, so you can see how the anatomy changes as you progress, through the patient. This is showing the first 16 slices of the coronal view. In the case of cardiac sarcoidosis, patients should have a high-fat, low-carb diet the day before the exam and then fast for 12 hours. Rubidium rest is completed. The purpose for the rubidium resting scan is mostly to evaluate them for any existing infarctions or pathology that may be seen on the images. And then the FDG is administered. Patient is scanned 90 minutes later. Maybe scanned for 10 to 30 minutes like a viability or whole body imaging like oncology where it's vertex to the toes. And the whole body scan is preferred if it is a suspected systemic disease. This is a sample cardiac sarcoidosis protocol. Patient will be fasting. They'll get the CT, rubidium infusion, PET scan. Then their blood glucose will be taken. They'll have FDG administered, and then they'll uptake for 60 to 90 minutes. At the end of that, they'll get their CT, and they'll either get a whole body PET or cardiac PET, and some patients may get both. This is an example of a cardiac sarcoidosis patient. This image actually has a pretty significant artifact. If you look at where the heart is placed with the perfusion portion versus the CT, this has a major misalignment issue with the fused images, and that's creating an artifact on the scan. With cardiac sarcoidosis, images can be visually graded for the whole left ventricle using a subjective scale or semi-quantitatively using the sum stress segments in the 17-segment model. This is an example of what the imaging would look like based on perfusion compared to the FDG portion. And that's it. Thank you for watching this presentation on FDG for inflammation and infection imaging.